He's interested in shaping a career that combines general clinical cardiology with advanced imaging, and he's also interested in high-value care, quality and process improvement, and health technology innovation. He's currently involved in research looking at echocardiography related to COVID-19 and aortic stenosis. On a personal note, he was recently married and has been taking advantage of the nice weather, exploring local hikes with his wife.
Thank you, and thank you, Dr. Gandhi, for that introduction. I wanted to thank everybody for the opportunity to start off this year's fellow debate series at Grand Rounds. And I'll be taking this moment to talk about the advantages to the high sensitivity troponin assay and push for implementing this assay as soon as we can here at Yale. I'm going to be giving you all a number of reasons why this is such a pressing issue. And I'll be reviewing data in terms of the utility, safety, and prognostic benefits of high sensitivity troponin assays. So why is this relevant and why should we be discussing this? Well, this is the most pressing issue at hand is that of emergency department overcrowding and dwell times. So a number of studies report associations with ED overcrowding and dwell times that are associated with adverse outcomes. And notably, chest pain is the second most common presenting complaint, accounting for over 6 million presentations annually in the United States. According to the ACC-AHA guidelines, serial troponin testing is a class 1 indication in the initial evaluation of ACS, and by necessity that can take up to 6 hours by guideline recommendations. And even though abnormal troponins are defined as the greater than the 99th percentile of a normal reference population in order to define myocardial injury, the ACC, in terms of lab accreditation, doesn't necessarily dictate specific testing protocols or assays. So we can actually reduce the duration of ED care for patients being evaluated for ACS by improving the troponin testing assay and protocol. So a brief overview of troponins. We all know the most common types of troponins that we see clinically. And at Yale, we have troponin I and troponin T assays. Troponin I is a point of care assay with a relatively quick turnaround time, but it has a lower sensitivity and negative predictive value than troponin T, as well as less precision. Both assays rely on the 99th percentile as a cut point per the third universal definition of MI, which was based on prior experience with CKMB. And previously, we had used the ROC cut point for CKMB as the cut point for troponin I, or for troponin in general. But now we use the 99th percentile because we know that lower levels of troponin do warrant a treatment. So what is high sensitivity troponin? Well, the high sensitivity actually refers to the improved analytical sensitivity of the most recent generation of troponin I and T assays. For this reason, some advocate calling this highly sensitive as opposed to high sensitivity. But for this purpose, I'll be using both interchangeably. So per the universal definition of MI, this assay should still identify the 99th percentile of a normal reference population with less than 10% coefficient of variation, which is a marker of imprecision. The higher sensitivity means they can detect lower concentrations of troponin than the prior generation assay. And given that the majority of people have an undetectable 4th generation or current generation troponin T, only a few fall above the 99th percentile, which is shown on the left figure, where we only see a portion of the blue curve above the 99th percentile, the blue curve representing a normal underlying reference population. With the 5th generation assay, we can detect lower levels of troponin, or in other words, in terms of the right figure, more of the blue curve representing the normal population underneath. And that's because, again, of the lower limit of detection of the newer assays. And because we can detect rising troponin values below the 99th percentile of that population, this can allow us to determine if there's a delta or a change in that value early on. Unlike chronic myocardial injury, acute myocardial injury should have a measurable delta. So this means we can no longer consider troponin dichotomously, or in other words, normal versus abnormal troponin based on whether or not we can detect it. Instead, we have to consider the value on a continuous basis and evaluate for change in relation to other clinical criteria for MI. It also means that patients that present very early on may still have undetectable troponin values, and patients presenting late may not demonstrate an elevated value or a delta. So in order to talk about how we got to where we are now, we have to look actually across the water to Europe, where high sensitivity troponin assays have been available since the mid-2000s. In 2009, Keller et al. Showed the diagnostic accuracy of the high sensitivity troponin I assay for early diagnosis and risk stratification of MI in a large prospective multi-center German study in patients that were presenting with chest pain and a high pretest probability of acute MI. And this was using a single troponin value. They actually looked at different durations of symptoms or the onset of symptoms in relation to the diagnostic accuracy of this single troponin value. And we see in figure 1 that the area under the curve for the ROC curves of this assay with different durations of symptoms was actually very high and higher than the traditional assays. In fact, the overall area under the curve was 0.95. And at any point from symptom onset, the sensitive assay had the highest and actually more profoundly robust sensitivity and negative predictive value, which we can see in the table here. At any point, again, from symptom onset. Notably, the specificity and positive predictive value were actually similar or slightly lower than the standard troponin T assay. And note that the negative predictive value is at least 95%. At the same time, Reichland et al. Published a similar study in the New England Journal, which was also a prospective multi-center European study. And this was looking at the 5th generation Roche troponin T assay. Again, looking at patients that were presenting to the ED with chest pain or angina in order to diagnose acute MI with a single value. The 4 assays they looked at, the 4 sensitive assays they looked at, had a significantly higher area under the curve for their ROC curves versus the standard assay, again in the range of 0.95. And these were similar for both NSTEMI and STEMI, and the negative predictive values were approaching 100%, also with a lower or unchanged positive predictive value. What was interesting was that this superior discrimination was even more pronounced in patients with more recent onset of chest pain within 3 hours. So following those 2 major studies, several follow-up studies, mostly based in Europe, showed significant prognostic benefit, which favored the high sensitivity troponin assays over the conventional assays. I listed a number of the findings here, but in summary, these studies demonstrated that the lower levels of detectable troponin, which were between the limits of the old assay and the newer lower limits of detection, still associated with short and long-term risk of death all the way out to 2 years in a continuous graded fashion, even in patients without acute coronary syndrome. Again, this suggests that patients that have a detectable troponin, whether or not it's above the 99th percentile, have an increased risk associated with that. Additionally, some found that clinically implementing a lower troponin threshold improved clinical outcomes in MI-related care. The new assays also had better prediction of coronary lesion severity. And the safety of the new assays was also important to see. We found that undetectable high sensitivity troponin T was associated with 0 death or MI within 90 days. And one of those groups actually showed that over time, these results had gotten better using even more sensitive assays. So the Merlin-Timmy group showed graded increasing risk between older and even newer assays with different cut points, suggesting again that this phenomenon of graded risk between the assays with more and more detectable troponin will continue as we get better assays. So some may argue that this would increase the burden of cases that cardiology may deal with, but note that this study was done in patients that already had a good history and story for ACS. So the low-level troponins that were detected here and associated with cardiovascular death or MI obviously should be taken seriously. Another important finding was that we started to see the reduction of diagnoses of unstable angina as more and more cases were detected with elevated troponin, which met the definition of myocardial injury or ischemia. Although on the whole, the absolute percentage increase was very low. And then some might also argue that picking up these low-level troponins can lead to additional downstream testing, because now we're suggesting that these have some risk. and that downstream testing may be inappropriate. So the same group out of Switzerland, among the APACE group, looked at this. In particular, they investigated the rates of angiography, stress testing, and time to discharge from the ED, again in a multi-center European cohort among 2,500 patients. And what they found was that there were similar rates of coronary angiography between the two periods of the conventional assay and then the new assay, and that these rates were not statistically significant in terms of their difference. They also found that the extent of atherosclerosis by the number of diseased vessels was also not statistically significant or significantly different. The rates of subsequent PCI and surgical revascularization were also unchanged. And while the rate of SPECT stress testing was similar, as well as the rate of abnormal findings from SPECT stress testing, the rate of exercise ECG testing actually was significantly lower after the introduction of the high sensitivity assay. And finally, the duration of stay in the emergency room was significantly reduced. They found that there was almost an equal increase in the number of those diagnosed with acute MI diagnoses with the number of decreases in unstable angina diagnoses, as I mentioned previously. And in those diagnosed with acute MI, the number of stress tests actually remained stable. And although the number of angiographies increased a little bit from 81% to 90%, there was no significant change in interventions. And in those without AMI, stress testing actually decreased by about 10%. So overall, there was no significant difference or change in the number in the downstream events. So this led to the idea of implementing the high sensitivity troponin assay in a sort of rule out algorithm in the emergency room for patients that were presenting with acute coronary syndrome. And again, it was important to view this in terms of an algorithm, because now we are saying that troponin should be viewed as a continuous variable rather than a dichotomous variable. And we have to have a way of dealing with changes in low-level troponin values. So again, those in Europe were the first to demonstrate this. This was out of that same APACE group by Reichland et al. As early as 2012. They demonstrated that when we check a 0-hour troponin T as well as a 1-hour troponin T, we can see very high negative predictive value and sensitivity, both with the initial troponin T value as well as the delta and the absolute value at 1 hour. Those that did not meet the criteria for rule-in based on cutoffs that they defined using their own reference population, or meeting the criteria for rule-in, were classified in this observational zone. And what they found was that the observational zones patients actually had higher risk of death than those that were ruled out at both 30 days and 24 months, which was similar to what was seen in earlier studies. On the right side, we see that they validated the same algorithm in a larger independent and international cohort with very similar negative predictive values with the baseline and 1-hour troponin T tests. I'll note that when we see more of these algorithms, about 60 to 75% of patients end up being ruled out, while about a quarter remain in the observational zone, and the remainder get ruled in. Here's a very similar algorithm, but this time with the high sensitivity troponin I assay out of the same group, again with very similar findings both in the derivation cohort and in the validation cohort. Again, the important similarities are that they are in patients that presented with suspected acute MI, and that we're looking at the two values, both the 0-hour and the 1-hour value. And then finally, the T-Rapid AMI study further validated these initial algorithms, again using the 0 and 1-hour troponin T high sensitivity assay, this time in a prospective international study that included a United States arm. Again, in patients presenting with acute chest pain or angina to the ED, but this time enriched for patients that were presenting early or less than 6 hours prior to presentation. And not surprisingly, they found, again, a high negative predictive value of 99.1%, similar to the initial pilot studies. And in those that did rule out, there was a very low 30-day mortality of 0.1%. So given that those data were so convincing, the European Society of Cardiology quickly adapted them and published a summarized 0 and 1 hour rule-out algorithm as an alternative to the 0 and 3 hour algorithm in their 2016 ACS guidelines. They specified a number of caveats, including knowing that the cutoff values are assay and population specific, meaning that we have to derive cutoff values using a local reference population. They noted that the algorithm should only be used in conjunction with all available clinical data, including assessment of chest pain characteristics and an ECG. And in patients presenting very early, within 1 hour from chest pain onset, the second troponin should actually be obtained at 3 hours. And that goes back to what we said earlier about the time course of troponin elevation. And they did note that repeat blood sampling is necessary if the patient is having ongoing or recurrent chest pain. So Phil might reference some of the studies that I mentioned and say, wait a minute, some of them actually use different strategies or different cutoff values than the others. So this actually was already evaluated by the same APACE group from Switzerland. They directly compared 4 of the suggested rule-out methods, and those included using the limit of detection of the assay, using a single cutoff value, which was slightly higher than the limit of detection, using a 1 hour and 1 hour change algorithm, and then finally using the 0 and 1 hour algorithm from the European Society of Cardiology, which combined both the limit of detection and the 1 hour algorithm. And this was explored in over 2,800 patients from 5 European centers. And again, we found that the sensitivity and negative predictive value were similarly very high for all 4 strategies. And the 2-year survival was also very high for all these strategies. They note again that these strategies should be used in conjunction with full clinical assessment and the ECG. Could we please mute the other microphones? Thank you. And then so Phil might also say, well, the US is very different than Europe, so those numbers are not going to likely work here. And I actually agree. The United States is very different. It's necessarily different than the European experience. We do have a high volume of ED presentations for acute MI annually with a very different burden of comorbidities. And we also know that cardiac biomarkers are used frequently, in fact, excessively, even in the absence of acute coronary syndrome symptoms. So this changes the prevalence of ACS in the population that we're testing here in the US, and that affects test performance. But we'll see that this actually isn't a major problem. And notably, even though this has been available in Europe for almost over a decade now, the 5th generation Troponin T assay was only approved in 2017 by the FDA here. So despite the differences between the United States and Europe, the high sensitivity Troponin T assay still has a very high negative predictive value. And this was seen in a prospective observational study by Peacock et al. In patients presenting with suspected acute coronary syndrome at 15 United States emergency rooms. And this was part of the submission to the FDA in order to approve the test. What's notable is that they established their own reference range from a separate 4-center study. And then in the test group, there were over 1,600 patients enrolled. And you'll see in table 1 on the right, they had a high prevalence of United States unique risk factors, including a high prevalence of CAD, hypertension, diabetes, smoking, and hyperlipidemia. They used 0 and 3 hour tests, initially using the 99th percentile as a cut point, as we'll see on the table on the left. And in all groups for different symptom durations, it provided a similar negative predictive value of about 99% at 3 hours, whereas a single baseline measurement at the 99th percentile had inadequate sensitivity. Although when they lowered the cut point to the limit of quantitation of the assay, which is slightly higher than the limit of detection, which was at a value of 6 nanograms per liter, the negative predictive value for acute MI and adverse 30-day events was also greater than 99%, both at baseline and at 3 hours. So overall, over 40% of patients with suspected acute coronary syndrome could be classified as low risk and theoretically discharged home after the 0 and 3 hour measurements. And this was all done without even considering clinical risk factors, which could further improve the baseline sensitivity of the assay. I'll briefly mention that this was quickly adopted by a couple of major academic centers. Mass General Brigham was one of the major centers that was an early adopter of the new assay and developed their own algorithm to incorporate it. So here's their 0 and 1 hour algorithm, which clearly specifies the cutoffs that they use to rule out or potentially rule in patients. What's unique here is that they incorporated the heart risk score for patients in the algorithm. And also I'll note again that the algorithm starts with patients arriving with chest pain or an anginal equivalent. I'll just kind of quickly move through the rest of the algorithm here, which has what they call a gray zone for patients that don't rule out or rule in. And in the gray zone patients, they do a 3-hour troponin assay and look at the delta as well. And then finally combine that with clinician assessment so that they can reach a clear disposition. So this clear disposition is actually something that's different than the ESC guidelines, because the ESC guidelines were actually a little bit vague as to what to do with each group. But here we see that there is a unique plan for each group of patients. Perhaps more clear and with some results is the UT Southwestern Parkland experience. You know, I might be a little biased having worked there, but Parkland is an ideal place to test this algorithm, partly because it's one of the largest and busiest ERs in the country. It serves a very diverse patient population of multiple different backgrounds, ethnicities, etc., as well as a number of uninsured and underinsured patients. And they continually are incentivized to lower resource utilization because they're funded by Dallas County taxpayers. And yet they were able to implement this high sensitivity troponin T assay in the year that it was introduced, using a 0, 1 hour, and if needed, 3-hour measurements, similar to Mass General in the assay. I'll note that what was unique to the assay was ultimately getting rid of what the ESC called the observation group and simply classifying patients as having been ruled out or abnormal. And in over 500 patients in their pilot assay, sensitivity and negative predictive value were around 100%, although their positive predictive value was low. But again, the purpose of this was to rule out, not rule in. And then in the 30 days follow-up period after this pilot, there was no recurrent MI, which again supported the safety of this approach. And this approach was actually studied even further over the subsequent 2 years at Parkland in over 31,000 emergency room encounters. What they found was that the ED dwell time had been declining slowly in the period before, but declined even further after implementation of this assay. And while the time from troponin draw and disposition decision was increasing in the period before, that rate of increase slowed during the post-intervention period. And about half of these patients had additional follow-up data where they found that the incidence of death, readmission for MI, revascularization with PCI or CABG was less than 0.01% over the follow-up period. And again, I think what's notable about this example was that this now demonstrates that the algorithm can be used in the United States. It doesn't rely on the 99th percentile upper limit of normal like some of the other assays. And we do see the incorporation of the heart risk score to better improve the sensitivity and negative predictive value to achieve this safe result. I'll briefly also mention that Phil might say that CKD is a tricky issue with high sensitivity troponin assays because patients with CKD often have elevated troponins. But 2 studies in 2018 demonstrated that we can still use the low troponin cutoff values to rule out about 17%, 18% of patients with the same algorithms. Although it's a lower number of patients that are ruled out, we can still use these assays. And then finally, Phil will perhaps get into the fact that Troponinemia has a wide differential. And while that may suggest to some that high sensitivity troponin assays lead to false positives, I'll say that we need to also consider the clinical history of why we're going down these pathways. And that some of these etiologies do in fact require the additional testing that we would normally do for CAD, including for some angiography. So why start now? Well, I hope I've convinced you that high-sensitivity troponin assays reduce the time needed for serial troponin testing. They can identify low-risk patients who can be discharged home safely from the emergency room. They can identify troponin elevation that our existing fourth-generation troponin assay tests cannot, and that graded elevation can help prognostication. It can be used in patients that do have chronically elevated troponins, such as those with CKD, and multiple cohorts, including those in the US, have validated its use in rapid evaluation algorithms that we can hopefully implement here. And that's what I'd like to leave you with, that as a leading academic medical center, we at Yale are not only well equipped to move forward with high sensitivity troponin testing, we have an imperative to do so and to advance forward into the future as a leader in this country. Thank you all, and I want to thank Dr. Gandhi for her advice, and thanks to Cecilia Berardi as well for some input on this talk. Thanks.
Good morning. Thank you, Nimish. I'd like to introduce your opponent today. Philip Chui has been chosen, or has chosen himself, to debate Nimish today. Phil, I'm surprised, is still on his feet after a very arduous day in the cath lab yesterday, standing side by side with me for an extended period of time. And we commented on that this morning. Phil did his undergraduate degree after having been raised on the West Coast at Stanford University. He then came east to Yale Medical School and then turned around and went back, sort of yo-yoing back to UC Irvine for his residency, and then swinging back around to come back to Yale for his cardiovascular medicine fellowship. Phil is very interested in outcomes research and has done an internship in such, and has been very active with Dr. Curtis in the core group. And Phil is going to present on the perils and pitfalls of implementing high sensitivity troponin testing. Thank you, Phil.
Good morning, everyone, and thank you for giving me the opportunity to speak this morning. Hopefully there's no technical difficulties. The title of my brief discussion this morning is, again, perils and pitfalls of implementing high sensitivity troponin and what I call no more negatives. I hope to provide a different perspective than that raised by Nimish, and to raise some important questions that we need to consider before implementing it here at Yale. So I just want to take this brief moment to highlight the importance of the topic we're about to discuss. Looking at data 10 years ago of a probability sampling of ED visits across the US, roughly 1/6 of all ED patients got troponin testing. As I will discuss later, I have some more contemporary data to suggest that these numbers have not changed at all in a decade. In that same cohort, almost half of any hospitalized patients got troponin testing, and 1/3 of these patients did not have any symptoms of ACS. And I'd like to point out that the authors in this study define ACS very broadly, including patients even with symptoms such as vertigo, abdominal pain, malaise. This data emphasizes the discrepancy between what is shown in trials and real-life practice in regards to judicious diagnostic test ordering. While we should be risk stratifying every patient for ACS prior to troponin ordering, in truth, we practice in a clinical environment where we don't do that. We just kind of go by order sets. The consequences of chest pain testing is far-reaching. In 2015, it was estimated to be roughly $7 billion to a healthcare system. I imagine that number is even higher now, 5 years later. I want to highlight the responsibility of us as cardiologists to lead this discussion on high sensitivity troponin. We are rarely the ones who order this test, yet more often than not, we are the ones who are responsible for interpreting any abnormalities. In some ways, I see it as on us to shape our own future. As we move forward in this talk, I hope to keep it in the context of 3 points. One, the science behind high sensitivity troponin is sound, if used appropriately, as Nimish very eloquently showed just before me. The point of my talk is really to highlight the systematic challenges of transition to high sensitivity troponin that we here at Yale have to anticipate. And my third point is that we have to keep in mind what I call the intermediate risk patients, who actually argue that biomarker testing is most relevant. And what I mean by that is that there are certain patients that broadly we already know what to do by history alone. The patients that come in with clear accelerating angina, those patients are going to get revascularized. The young patients around 20 years olds with chest pain syndrome, very atypical stories, those patients rapidly get ruled out. But while the majority of patients who come through ED with some risk factors, sort of an atypical story, that's the population I'm talking about. So let's first begin by discussing what constitutes as a normal or abnormal test. So how does the lab tell Epic to flag that result in red, which I might add after a year of consults is the color alone will lead to a cardiology consult. So for current troponin testing, what is abnormal is set at the 99th percentile of the upper reference limit of a healthy population. So you might ask, well, what is a healthy population? That's an excellent question. So one study looked at this specifically for high sensitivity troponin. And what it did was it combined 3 community-based cohorts. The first was the Dallas Heart Study, which is a probability-based sampling of 6,000 adults near Dallas County with intentional oversampling of African Americans to constitute roughly 50% of the entire cohort. Among other things, they took routine sampling for high sensitivity troponin from people 30 to 65. There's 2 other studies, which is the ERIC, or the Atherosclerosis Risk and Community Studies, and the CHS, or Cardiovascular Health Study, which are similar cohorts with around 15,000, 11,000 adults scattered across several counties across several states. And what do I see here? If I can kind of focus your attention on figure 1, across different subcohorts of both just by age and sex, you see that there's a large kind of reference population of what a quote-unquote normal troponin is. And on the figure already on the left, this patient was free of any cardiovascular disease such as AFib, heart failure, CAD, as well as CKD. Each of the bars kind of represent 95 confidence intervals, and they use a commonly referenced 14 nanograms per liter as a reference range. But you can see again, especially in older men, the variation is quite stark. But then they will look at, well, what about subclinical cardiovascular disease? And so that's kind of the figure 2 on the right. And here they took out any patients that had any LVH1 echo, any BNP elevation, and any patient with a LVEF of less than 55%. You do see some reduced variation across the cohort, but overall, there's still marked variation. So imagine all these patients, especially, let's say, in the men over 75, all these people walking into the ED, they're going to be screen positive. On a side note, one might argue, you know what, why don't we just set a higher 99th percentile value for older age groups? But that's unfair, because if the increases are actually caused by comorbidities, then those who are particularly healthy will be disadvantaged by the sensitivity of the test. Selecting an appropriate reference range gets even more difficult, as even routine medical problems can cause elevated levels. In a study on the left, they took 700 volunteers who were all over 45, and these are relatively healthy individuals. The first group who are illustrated in green were patients who did not have any history of any vascular disease, diabetes, who are not on any cardiovascular medications, which include the usual culprits such as aspirin, beta blockers, ACE and ARBs, statins. Then they subdivided that population into patients who had no blood pressure ever over 140/90 on repeated measurements, LVEF greater than 50%, entirely normal ECG, and a GFR over 60. And already between the red and the green, you can already see there is some difference in what the average high-sensitivity troponin level is. Then they further subdivide that group into the most stringent group, which is the group in blue. And these patients had to fulfill all the above criteria, as well as having no valvular disease, any wall motion or abnormality on echo, normal fasting glucose, and no other comorbidities such as hypertension. So even though the smallest routine medical problems that we don't even bat an eye, such as hyperlipidemia, that already might cause your high sensitivity troponin level to go up. So I think the graph on the right reminds us that as we use more criteria to define a reference range, it will push the reference range towards being lower. That will affect your sensitivity and specificity. So to recapitulate, the appropriate reference range is really poorly defined. It's especially pertinent to those in the intermediate risk group who are those kind of middle age with a few risk factors, or in other words, the patients we often see in clinic or even in the ED. Perhaps more importantly, as we want to maximize the negative predictive value of our test, we want to push that reference bar lower. So what we need to expect is that a large portion of our patients will screen positive, and Nimish kind of referenced this point. Some have shown that up to 1/2 of patients in ED will screen positive. Well, I've been practicing medicine, perhaps shorter than most of the people on this call. I've seen that I practice a number of healthcare systems, and I consistently can say many clinicians see troponin as a dichotomous value, meaning if it's positive, they're going to call cardiology. And honestly, here at Yale is no different. It doesn't matter if the patient 92 has a hemoglobin of 3 and is having a GI hemorrhage. If that troponin is positive, cardiology likely will get a call about it. And I say this half jokingly, but if you present an ED with a complaint somewhere between from your head down to your knees, you're going to get a troponin test. So what will happen if we incorporate a test where just in a general population, over half of people will screen positive? It's not just your colleagues in the ED, but also many of the hospitalists, medicine residents, and even our surgical and psychiatry colleagues will have to adopt a paradigm shift. Is this really practical? I just want to clarify that no way am I poking fun at the people in ED because the job is extremely difficult, but I hope you can appreciate that the test is extremely nuanced that we in cardiology are only beginning to understand. So I just don't see how it's possible in this large healthcare system that everyone is on the same page. Adding to the complexity is that there's a lot of biological analytical variability. On the left is an interesting study where they took young 20-year-old healthy patients and took repeated sampling of troponin levels across different hours in the same day. And troponin follows actually a diurnal pattern, which is something I learned, where it's actually highest in the morning and peaks again in the evening and kind of nadirs out later in the afternoon. While the absolute change was very modest, it does highlight there is some biological variability. This is perhaps better illustrated in the lower left graph, where they took this is the same study, but they actually did it on different weeks then of the same patients. And the absolute values now become a little bit more marked. Then there's actually a component of analytical variability. On the right, there's a table of different troponin assays. CV stands for coefficient of variation, or the standard deviation divided by a mean, which is just a measure of analytical precision. I want to emphasize that with high sensitivity troponin, the assay really matters, especially if the result is ever so slightly positive, because knowing the assay characteristics, then are you able to determine that the result is a true positive. Again, it adds a kind of another wrinkle to all this, kind of to keep in mind which assay you're using so you can know how to interpret it. As Nimish pointed out earlier, and because there are problems of high positive screen rates in high positive screening rate, most algorithms have built in what we call a delta or recheck component. Here at Yale, the median processing time after talking with a clinical lab director, Dr. El-Khoury, the median time is around 33 minutes and ranges between 30 and 60 minutes. And so we're looking roughly here at the 3-hour sample if we were to adopt this at Yale. Even between several standardized algorithms, you can tell there's slight differences, but they do exist. I also want to emphasize that these assays these algorithms are somewhat assay specific, so it only works if we use the same assay as they do. Earlier in this debate, we talked a lot about ruling out patients. But what about on the other side of the coin? Use troponin to not only to rule out MI, but also to risk stratify who are actually having one. Even now, obviously, we don't treat a trope of 0.5 and 5 the same. And after all, it would be in our best interest to tell the emergency department to call us for patients with the most concerning stories of patients ruled in, and not just every single patient who are ruled out, because that population will be enormous. So as you can tell from the table shown, there are numerous strategies to do so that are widely discrepant. Unfortunately, they are all a bit different, and continually we have to balance sensitivity and specificity. So when we develop and refine our own protocol here at Yale, we have to keep in mind that as we change the parameters around, a positive predictive value and a negative predictive value will also change. As you can all guess, the algorithms are presented often break down in certain populations. Nimish kind of referenced the CKD study, and here I'll reference another one. The study that they usually use a German study where they took 2 data sets from prospective multi-center kind of biomarker studies. And so they specifically looked at CKD patients, and the average GFR is around 45. They took out any patients on hemodialysis who were recently hospitalized, who had a hemoglobin of 10 to reduce some confounding. They found that actually over 3/4 of patients were screened positive using traditional high sensitivity troponin algorithms. And then the median troponin value in these patients was around 30, with higher variations than normal, and the numeric actually rise and fall. The first algorithm on the top is a proposed algorithm for high sensitivity troponin I, and the second is for high sensitivity troponin T. And you can kind of remember in comparison to the diagram I showed in 2 slides earlier, here they recommend relative percentage differences rather than absolute differences. There are several limitations to this study, such as validation of the model in the same cohort from which they derived the models from. But the point I want to emphasize is that in certain subsets of patients, they may need to be modified from standard, kind of a general standardized protocol for ruling out or in patients, which makes this process even more difficult. So while I just kind of gave you a snapshot of the different algorithms, hopefully you can understand that the delta is crucial in the implementation of high sensitivity troponin. That delta, though, varies significantly by a reference population, assay, and which protocol you use, which only adds to the confusion for people, especially if they're not well versed in the literature. I want to highlight one of the studies that Nimish brought up that kind of focused on contemporary UX experience on high sensitivity troponin. In that study, they actually used the same assay as we have here at Yale. In a study, they did have different cutoffs between men and women, and they found that if you set a cutoff of 99 grams per liter, you had excellent negative predictive value, especially if both tests fall within that range by 3 hours. It's definitely one way to rule someone out without worrying about the delta and all. But in this study, I want to highlight why I think is that kind of they ignored a number, and that's a positive predictive value. Here, they only got roughly 40%. And I might add that when you dive into supplemental material and flush out who actually was enrolled, those patients with typical anginal symptoms and excluded patients with other possible primary diagnoses. As you all might know, people order troponin in a much wider array of cases, which would drop that positive predictive value even more. In one recent meta-analysis in Annals, combining several high sensitivity troponin studies was around 20-something% for a positive predictive value. And I want to say, do these strategies of selecting the most patients with the highest risk of ACS, is that really reflective of actual clinical practice today? As with any diagnostic test, and I've alluded to this earlier, there's always a balance between sensitivity and specificity. This graphic is kind of a nice presentation of what each generation of troponin is now captured. Whereas in the current generation of troponin, only a few of the patients in an intermediate group will be captured, what we now attribute often to type 2 MIs or demand ischemia. In the 5th generation, all of these patients will be essentially flagged as positive. I'm sure all of us have seen this table at some point or another, but it's a good reminder of all the different and varied etiologies that can cause an elevated level of troponin. These correspond largely to what the Yale portion of graph earlier, and argue that almost everyone admitted into the hospital will have at least one of the below pathological conditions during this state. This is probably contributing to the low positive predictive value we observe in the high sensitivity troponin data. So many of you might argue, why does a positive predictive value matter, right? Isn't the point of the test to rapidly rule out patient in ED? I argue yes and no. So perhaps the kind of the below vignette, illustrates the point. We have an older lady without history actually of CAD, but some risk factors comes in shortness of breath, with maybe some thoracic chest pain, found to have a large capacity in X-ray, but because they, as a part of the order set, they order a troponin, and that's slightly elevated. So they call it as an NSTEMI, they end up admitting a patient, they consult cardiology. So the average, actually looked up the average overnight stay for a hospital bed here in Connecticut, it's around $2,500. This actually excludes any additional troponin tests, the lab, EKGs, any medications, PRN or home medications. And then, some of us, when we get the consult, we say, you know what, I don't feel comfortable just sending this patient right home. I want to stratify this patient more. So then we get an echo, and that's around $500, and actually pull these numbers or these dollar amounts actually from Epic. And then you get order a nuclear stress test, which is around $1,200. And I'll just say that in places outside here, or perhaps less advanced cameras, it's not uncommon to get a stress test that's kind of indeterminate, and so you end up getting a CAT. And if you can imagine a kind of a community setting where your income is RVU based, there's almost a perverse incentive to go down this road. And that's a kind of error, but the diagnostic angiogram here in the US is probably around $10,000 instead of $1,000. So especially in this pandemic area, not only do you have a massive financial kind of burden to all this, no patient wants to stay in the hospital any longer than they actually have to. So it's kind of a mental stress issue too. So I kind of want to hope to back up, my above story with some data to suggest that, there are some consequences of a test with low positive predictive value. As some of you are aware, I've spent some time developing a database of patients presenting to ED in the VA system in regards to kind of ACS workup. So in this cohort, we draw from all 121 VA sites across the nation from 2015 to 2017, so it's actually rather contemporary data. And I actually took out all the patients without any laboratory study. So I think the initial was around 7 million patients total, and it dropped to around 3 million. So of that patient population, 1/3 of patients will get troponin test. And as you can probably reflect, troponin testing is still really widely used, and I actually might add perhaps excessively used. And then with all these patients, I try to track what the peak troponin level is and actually downstream utilization and outcomes. And throughout all this, I also have the comorbidities, the basic clinical information such as the vitals, BMI, and lab values such as hemoglobin, creatinine. So even though I don't have specific information on the high sensitivity troponin, I did kind of actually look at the patients who had what we call very slightly positive, which we often attribute to demand ischemia. And here we defined it as, or I defined it as patients who had it less than 3 times the upper reference limit normal. So these are here at Yale, we have Trop-T of 0.07, 0.08. And then I separate the 121 facilities in quartiles based on the proportion of patients that had what he calls ever so slightly positive. And obviously this table is done with adjustment for all the patient and the hospital level characteristics, including how big the hospital was, how many ICU beds they have, and whether they have a cath lab or not. And as you can tell, the sites with the high proportion of patients with these ever so slightly positive troponins had increased downstream utilization. They had higher emission, stress testing, and routine echoes. But interestingly, they didn't have any significant difference in revascularizations. So it's kind of suggesting that this increased testing actually isn't associated with a better probability of picking up significant, coronary artery disease. I mean, as with any observational data set, there obviously is kind of component of residual confounding. So I just threw in a kind of falsification endpoint to prove that it's not that patients in a higher quartile are just sicker. As you can tell, they're all 4 sites are using the same level of KUBs, which is not correlated troponin. So it's not just the higher facilities or testing more or higher sicker patients that's counting for all these differences. I think hopefully I've convinced some of you that there is a real life significance to a simple lab test and with downstream resource utilization. I think all too often as clinicians, we often order tests to make ourselves feel better, but the actual benefit to patients likely marginal. This area of high sensitivity troponin will only lead to a capture of a lot more abnormal results, resulting in that intermediate risk group where the decision making is more complex. We have to be conscientious and do our best not to practice defensive medicine. So while Nimish really hashed out high sensitivity troponin in the role of ACS, just want to take a last few minutes to kind of explore what is it and associate with different other patient outcomes. This analysis looked at the ERIC study, which I kind of referenced earlier, which is the atherosclerosis risk and community study, which is around 8,000 patients, around 54 to 74, with an average longitudinal follow-up of 15 years. And they all did not have cardiovascular disease at baseline. In this study, they checked their high sensitivity troponin around during a scheduled follow-up for all the patients. I probably apologize, the graph is a little bit perhaps small to see, especially on people on their phones. But here in graph A, they basically the graph of incident cardiovascular coronary heart disease or coronary artery disease, and B is stroke, C incident AS-CVD, D incident heart failure, E global cardiovascular disease, which is more or less a combination of the above and overall death. What they consistently found was that the patients in the highest quintile of high sensitivity troponin had the highest risk of developing cardiovascular disease and death. And these lines were very divergent. And the patients in the highest quintile often had hazard ratio of over 3 in reference to their first quintile. And this risk was independent of traditional risk factors. So you might argue that we know that for some time now that patients with higher troponin levels especially inpatients, do worse overall. We have some of the strongest data coming from the BRACE registry. So what is new about this? However, I would argue that most patients did not have a detectable fourth generation troponin, whereas in here, the high sensitivity troponin was detected in over 85% of patients. This study then also incorporated high sensitivity troponin in their pooled cohorts equation. I think that's pretty fascinating, and it improved the accuracy in estimating risk of ASCVD. Interestingly, the Spearman correlation between troponin I and T was only 0.7, suggesting that the two assays provide complementary rather than redundant data. And that's maybe kind of suggestion that here at Yale, we should also have both assays as well. The following study, they used a Swedish registry of all patients who came in for ACS. And here is around 48,000 patients across 45 hospitals in Sweden. And they separated them based on different groups, based on their high sensitivity troponin level. And there's just several findings I kind of want to point out. In the graphic on the left, on the bottom is kind of the different tiers of your high sensitivity troponin level. On the left is your, on the y-axis is your hazard ratio for risk of death. And they actually found that once you hit the 14 nanograms per liter, for which 75% of the population is over, your risk of death actually started climbing. But these patients overall had low risk actually of type 1 MIs. From that same registry shown on the right, where they divided patients into different quartiles, the first one being the one who fell below the 99th percentile as the reference range, and the three remaining tertiles as the ones with the abnormal high sensitivity troponin. In the first subpool cohort, they actually excluded all patients with previous MI, PCI, any revascularization, as well as stroke and heart failure. And here, the whole study excluded any patients that did not have a diagnosis of actual ACS once they left the hospital. So the outcome was adverse events or MACE, and as you can tell, across both subcohort 1 and 2, tertile, as you go up, patients did overall worse, especially in the third kind of tertile. And perhaps the most interesting is the third subcohort, and these are patients who actually got cath and who got echo and did not have any significant coronary stenosis as defined by as defined by kind of a lesion greater than 50% or LVEF of less than 50. And interestingly enough, despite cathing these people doing echo, these people still actually died much more. And when they actually looked at the correlation of high sensitivity troponin correlated much better to heart failure than actually did with ACS. So kind of take home message though is that in these patients with elevated high sensitivity troponin, it's not simply enough just to cath them, do echo on them, and call it a day. These patients clearly remain at risk. This same kind of association has also been seen in the surgical literature, as well as COP, diabetics, and CKD patients. Here, I just want to highlight in the surgical literature, whereas a prospective cohort, 21,000 patients across 13 countries, and these are all patients who are 45 years and older. So just for the sake of time, kind of gloss over this a little bit, but main outcome, what they call was what is myocardial injury after non-cardiac surgery. It's kind of this outcome defined as surgical literature where it's patients with elevated troponin, but no definitive other diagnosis to explain it. So what they found was that 18% of these patients, after they just did routine perioperative high sensitivity troponin monitoring, fulfill that MINS criteria. And actually 22 of these patients actually kind of met symptoms of what you would now actually call type 1 MI if you use universal definition MI once they start using EKGs and echoes. However, 68% of this population had no symptoms at all. And so overall, of all the patients who actually had MINS, 91% of patients did not have any symptom. To kind of rephrase the numbers above, the study suggests that almost 91% of patients or 68% of the MIs would be missed if we did not use kind of perioperative or preoperative high sensitivity troponin measurements. And there's obviously a prognostic aspect to this too. And so in both parts were red, either if you have an absolute, where they divide it by threshold, the minute your high sensitivity troponin level goes up, or there's absolute change in the high sensitivity troponin, the risk of death kind of increases dramatically. There are some limitations to this study that I won't dive into for the sake of time, but it doesn't detract from the overall message that it's not unrealistic in the future for all post-surgical patients to get routine high-sensitivity troponin monitoring with or without symptoms. Most of the data I kind of present to you has come from either registry data or prospective studies where high-sensitivity troponin was measured as a secondary variable. The largest randomized trial, to my knowledge, is what we call a high STGA-CS trial, or the high-sensitivity troponin in the evaluation of patients with suspected acute coronary syndrome, which is a stepwise cluster randomization study in 10 hospitals across Scotland. And at 2 phases, where actually they had a validation phase where they used a conventional troponin level and a high-sensitivity troponin as implementation phase. And over time, all 10 hospitals will ultimately use a high-sensitivity troponin to kind of reduce some selection bias. A total of 48,000 patients were included. And they kind of had an independent panel adjudicate each troponin level as to what they call your type 1 MI, which we're all familiar with, type 2, which is basically people with some evidence of ischemia, but no obvious diagnosis of atherosclerosis, and what they call acute injury or chronic injury. Most patients fell into acute injury unless the levels were flat, at which point they became chronic. On the figure on the left is a beautiful presentation of different etiologies for the for the troponin elevation. As you can all appreciate, the majority of acute or chronic injury are actually due to ischemic heart or not due to ischemic heart disease, as we commonly associate troponin to be. And in the picture on the right, the green line on the bottom are those without any kind of myocardial injury. And as you can imagine, patients with type 1 MI had the highest risk of cardiovascular death, but actually had the same levels as a reference population for non-cardiovascular death, and the patients with the highest acute injury had the highest risk of non-cardiovascular death. And in the same study, then when they switched over, actually all patients later, or all sites later, switch over to the high sensitivity troponin phase. And what they found out was that once they switch over, there was higher rates of antiplatelet use, higher rates of coronary angiography, but the PCI rates were actually the same. So did this, and once they switched over, did it actually lead to a change in outcomes? Not really. Actually, a total of 17 patients were actually later adjudicated to have type 1 MIs. But as you can tell from the graph, for both the primary outcome and secondary outcome, the calculated odds ratio all cross a line of unity. So even though we are capturing more myocardial ischemias, it's unclear if we act on them in traditional methods, it'll lead to significant changes in outcomes. I actually could not fit it into talk, but when compared to troponin T, high sensitivity troponin is actually better prognostication outcomes than a 4th generation troponin T is. So going back to what I call the intermediate risk group, the 5th kind of take-home point is that hopefully I convey to you is that as we move to high sensitivity troponin, we're going to catch a much larger wave of these mildly elevated levels in patients we previously thought we would not be able to detect. And it's actually a good thing, because this is a prognostication standpoint. It gives us perhaps an opportunity to intervene that we previously may be unable to do so. Yet the responsibility falls on us to know what to do with these patients. And I might add, there's actually very little information and very little data on what to do. Here is actually the algorithm that Dr. Al-Khoury from Clinical Lab Medicine forwarded to me of what Yale's proposed algorithm is. And actually, we've been trying to develop this for 2 years now. And for one reason or another, we kind of didn't make too much progress, especially since COVID hit. It does incorporate the heart score, which I might add really applies only to the ED, and the heart score is on the right. And just for simplicity's sake, as you can tell, it's actually not too hard to kind of hit a heart score of high probability or 7, especially in the patients we often see in the ED or pretty high risk. So recently, Jack kind of published what we call scientific expert panel guidelines on helping institutions transition. We have used the same document here to help kind of Yale, transition and to guide us. I would actually argue that under the clinical laboratory preparation, they are mostly ready. They have assays selected. They have percentiles kind of selected as well, and they can process it in a pretty reasonable time. However, on the opposite end, we are not ready. There has been very limited kind of sessions to educate clinicians. The ED is perhaps the most streamlined component, but on the definite inpatient side, most clinicians do not understand the differences between the different assays, do not understand the differences between injury and infarction. And the differential diagnosis is extremely broad, and it's going to lead to a huge influx, what we call tsunami, of cardiology consults that we're just simply not prepared for. And are we as cardiologists really ready? I put a big arrow next to that, again, that intermediate risk group where these patients have a little bit low levels of elevated high-sensitivity troponin. Clearly, we know now these patients do die more, have worse outcomes, but we don't know what to do with it. So are we just going to broadly test across the board with diagnostic testing, hoping we find something so we can intervene on? And what if we don't? And is that really judicious of resource allocation? So kind of where do we go from here? On the left, I kind of, again, have my summary points. But I hope to end this kind of discussion with actionable, points to take home. And most importantly, education is crucial. It's going to be, but I'm not going to shy at it. It's going to be extremely expansive. We have to basically educate everyone down the emergency department, inpatient side, and almost everyone in the hospital. And we have to somehow give feedback to people who are ordering incorrectly. And how do we do so in kind of a political manner? And we really need a clinical leader to take this on, someone to spearhead this. And I would argue it's probably from our section because we are shaping our own future and best equipped to do so. I think it's best to start in ED with the lowest risk patients just to iron out any kinks and kind of work our way up. And I don't think we should kind of roll out both assays at the same time to the broad population because I think it will only confuse people. I don't really have a kind of answer for the next point, but high-sensitivity troponin really has to be combined with clinical decision-making. All too often now, I see people order diagnostic tests as a fishing expedition, especially in an acute situation where they order rainbow labs and people are crashing. Just order everything and see what comes back positive. Some people might argue, well, high-sensitivity troponin gives you a risk profile in patients, and I don't think that's really practical. You can't just tell a hospitalist or an internal medicine, hey, your patient has a 3% chance of having MI in the next 30 days and just leave it as is. Who's going to be comfortable with that? And I think the more exciting part is, while high-sensitivity troponin has been largely studied in the acute ACS population, more and more is going to move to the outpatient setting. And it's a space where I think is exciting for future prospective trials, and similar to how CRP was in the Jupiter trial. Will patients who are otherwise healthy but have an elevated level benefit from statins or more aggressive blood pressure control? I think these questions remain unanswered, and I think this technology will even better shape patient outcomes more than anything, especially from prevention standpoint. Just want to give a quick thank you for Dr. Brennan, who's been kind of helping with this. Dr. Gandhi also has been helping me develop my database for the past 2 years. Nimish presented an excellent slide previously, and especially a big shout out to my fiancée Gloria, who I will actually not really be here at Yale without her support. And again, the future really is high-sensitivity troponin. That future is here today, and it's really our job to be ready. Thank you.
Excellent job, Phil and Nimish. You guys both presented outstanding data on both the advantages and disadvantages of transitioning to high-sensitivity troponin. Since we're already over time, I'm just going to try to highlight some of the major points which both of you have already covered quite nicely. So as we learned, the biggest advantage is a faster and safer rule out. We certainly can reduce the amount of time from our current assay that we have at Yale and at the VA to a much shorter and safer rule out. A survey of ER physicians showed that an acceptable miss rate for cardiac chest pain is less than 1%. And with some of the algorithms and the high sensitivity assay that we were shown earlier today, we can achieve this high bar. And as Nimish has also discussed, a high percentage of patients can be discharged much more quickly and again, more safely. Both Phil and Nimish have touched on the improved stratification. Another concern has been possible increase in downstream testing, but overall, this has not been demonstrated in large-scale studies. And on a whole, the rate of coronary angiography is similar, along with the anatomy that's detected. And there's also some data from Europe to suggest that the strategy is cost-effective. So I just want to take a step back because Phil had mentioned a lot of the nuances of each of the algorithm and the delta. But ultimately, there are always a few concepts we have to take into consideration when we apply a diagnostic test such as a biomarker. At baseline, we are all clinicians, and we all need to use this one tool to supplement our clinical judgment. And so the interpretation of the troponin value is only a portion of how we assess our patients and how we provide their care and management. We always have to consider the pre-test probability and the prevalence of the condition. And as both Nimish and Phil have addressed, it's important to only order a troponin, and especially a high sensitivity troponin, in an appropriate patient population. Additionally, we have to apply our differential diagnosis to the interpretation, and elevated troponin does not mean MI. This is a figure from the fourth universal definition of MI and shows some of the conditions that both Nimish and Phil have presented that can lead to elevated troponin values in some patients. Not everybody with kidney disease will have myocardial injury. Some will have myocardial injury without infarction, and some will have evidence of either predominantly type 1 or type 2 infarction. So on this spectrum, it's our job as clinicians to figure out where our patient falls and the best way to incorporate the data that we have from troponin testing to optimize their care. I want to again caution everybody against the term false positive, as we've already discussed today. On a whole, with some of the large-scale studies, including the Chapman study that Phil presented, there is a mild increase in detection of MIs. In that particular study, it was 3.3%. Some of these are due to reclassification of unstable angina, and others are due to an increased detection of type 1 MI. And both Phil and Nimish highlighted the patients in the observational zone, and this is about a quarter of the patients tested, and in those, up to a quarter end up ruling in for MI. So these are not false positives, but actually true positives that can impact how we care for our patients. Phil highlighted data from this study, again, showing the prognostic value of elevated troponins, either due to type 2 MI or acute or chronic myocardial injury, in addition to type 1 MI. And as we can see in the navy blue bars, this is the risk of cardiovascular death or MI at 1 year. But what's even more striking is the all-cause death, particularly in these three subgroups. So although we don't have the ideal way of managing these patients, it does signify increased risk. And at the very least, we can use this as an opportunity to modify their risk factors and ensure close follow-up to, again, try our best to optimize the care of these patients. So this is a figure Phil has already demonstrated. And as I'd like to just close by saying that it's not a matter of if we transition, but when, and we already have some of the basic underpinnings ready to go. But as Phil and Nimish both highlighted, the key is really going to be education, intense education on all of those who will be ordering and interpreting these tests. We will need to collaborate with our colleagues from emergency medicine, laboratory medicine, internal medicine, critical care, nursing, and we will all have to work together to come up with what algorithm we think is best to serve our patient population. We've seen evidence from what Nimish presented from UT Southwestern, how in a very busy clinical and diverse patient population, we can come up with a successful algorithm and correctly care for our patients. So there's no reason that at Yale we can't do the same thing. Thank you.
I actually didn't want to interrupt that. I'm going to try to share my slides. I'm technically challenged, as people know. So I'll be very brief since we're well over. I want to thank Nimish as well as Phil and Parul, obviously, for a nice summary. I was actually going to throw a little bit of levity in this and speak about what a strange trip it's been as we go over the years. Beginning in 1988, when Lee Goldman actually presented a computerized algorithm for the detection of myocardial infarction, and that literally was a computer algorithm entered manually of 6 community hospitals in this general area, and showed a significant sensitivity and specificity with determining myocardial infarction, something not dissimilar to what we're currently seeing even with the high sensitivity troponins. We're now been graced with a number of risk scores, and as you can see, we use a lot of different risk scores. The cardiac biomarker history is as delineated. And we also know that obviously, and everyone has pointed out, that the analytic performance of the troponin assays has resulted in superior sensitivity and precision. There are a number, however, of non-ACS etiologies that both parties have pointed out that lead to cardiac troponin elevation. The key thing is obviously there is going to be a challenge of discriminating between acute and non-acute high sensitivity troponin elevations and between type 1 and type 2 myocardial infarctions. We still need to ascertain, and there's difficulties with that, the optimal duration of the rule out. And obviously, this high sensitivity troponin can risk stratify patients with disease conditions other than acute MI. As everyone has again pointed out, these assays should only be used in conjunction with the full assessment, including a pre-test probability assessment, and they should be considered triage strategies rather than definitive diagnostic strategies. There is a writing group involved with the high sensitivity troponins, and they have advised against conversion to high sensitivity troponin without a graded educational phase that involves all clinical services. And this is well marked in this, published in the JACC article, delineated by all parties, that there has to be a significant amount of interplay between all services as this is rolled out. I do agree it's time. In 2009, Apple put forth that a tsunami is coming based on European data. In 2013, Jaffe and Morrow said, we are ready, let's go. It is now 2020, and we haven't initiated this process yet. So speaking to Dr. El Khoury, the lab director, what we need is volunteers and certainly clinical leaders to get this progress off the road. I'll stop there because I know we've gone way over. Thank you. Questions?
Samit asked a question in the chat. What is the downstream effect on appropriate use of PCI? I'll mention the study that I brought up earlier. I can pull the slide up as well. But basically, there was an increase in angiographies for patients that did rule in, but the rate of PCI did not actually increase in that group. And the rate of angiography in the patients that were not diagnosed with AMI